Thank you for having me along to the Health Ed team to talk on a topic very close to my heart, scoliosis in children and adolescents, and how we're able to prevent surgery in these kids. My name's Dr. Mike Selby. I'm a spinal and orthopaedic surgeon. I work at the South Australian Scoliosis Service based here in Adelaide, as well as the International Spine Centre, where I gave this talk originally at the conference. It was in June, and that was Scoliosis Awareness Month internationally, as promoted by our Scoliosis Research Society. So what is scoliosis? Just a refresher. It's a side-to-side spinal curvature in the coronal plane. It often presents with uneven shoulders, shoulder blades, ribs or hips, and the spine is actually a driver for this, but perhaps sometimes the least obvious of those problems. When we measure scoliosis, we use what's called a Cobb angle, and to be a true scoliosis and not just a tilt of the spine, this Cobb angle should be greater than 10 degrees. Often on an X-ray like the one you're seeing here, which is a fairly obvious high magnitude scoliosis, you can see an S shape or a C shape or question mark type shape visible on the AP X-ray. The most common type of scoliosis is adolescent idiopathic scoliosis, otherwise known as AIS. It is more common in girls, and severe pain, surprisingly for many, is relatively uncommon in adolescent idiopathic scoliosis. Some patients will have fatigue-related pain or muscular pain, but it is unusual for them to have severe pain at a young age associated with this curvature. So there are many potential causes of spinal curvature or scoliosis. These are divided broadly into non-structural curves, which are not associated with any rotation of the vertebra, and structural curves, which tend to be more associated with rotation. Non-structural causes include poor posture, leg length discrepancy, occasional trauma, tumour, infection, or nerve irritation, sometimes due to an adolescent disc protrusion. Structural causes include idiopathic scoliosis, which is the most common type in the adolescent years. However, it can occur in an early onset format below the age of 10 years. Neuromuscular scoliosis can be seen with conditions such as cerebral palsy, as well as a range of other rarer conditions, as well as the muscular dystrophy group. Congenital scoliosis is being increasingly diagnosed on ultrasound scans while the baby is still in utero. Often the cases are mild, but sometimes it can form a more significant problem requiring bracing or surgical treatment in young patients. And then there are other causes such as metabolic disorders, neurofibromatosis, collagen disorders, for example, Marfan syndrome, and post-cancer treatment, say irradiation. The best way to diagnose scoliosis is to look for it, and it presents most commonly in teenagers. Teenagers are pretty good at hiding their back, but looking for it is the key. These sheets here perform a function of patient awareness and are part of a Scoliosis Research Society campaign. And these are the signs that we can also look for as doctors when we're assessing young patients. Number one is an uneven rib cage. Number two is crooked shoulders or asymmetrical shoulders. Number three is a head tilt to one side or the other. Number four is a shoulder blade prominence, again, one side more than another. 5 represents body tilt, and you can see an example there in that clinical photograph. 6 is uneven legs, and 7 is jutting out of one of the hips. So one of the hip bones can appear more prominent than the other. And this can be something noticed by the patient themselves, sometimes parents, sometimes a sports or dance coach can notice these clinical signs of scoliosis. But one of the best tests you can do is an old-fashioned test called the Adams-Ford-Venn test. And this is from the Scoliosis Australia website, and this is how scoliosis can be detected relatively easily. So when you see a patient with suspicion of scoliosis or curvature within the spine, doing a Ford-Venn test where you look for asymmetry in the chest regions, thoracic spine, or the lower back lumbar region, of greater than 1 centimetre. This is a very reliable indicator of potential scoliosis and means that referral for further investigation in the form of plain radiographs is indicated. So again, this is another example of Adams-Ford-Venn test where the rotation is being demonstrated. And you can see there's clearly a 1 centimetre difference in the side of the spine on the right compared to the left here. But also in addition to this, the angle is being measured by placement of a ruler and the use of a simple phone spirit level or measuring guide there to assist in measuring the angle of rotation. This is one of my patients who has a public Facebook blog documenting her journey with scoliosis. She had a very severe curve of 99 degrees on presentation, and you can see here her clinical photographs, which she has shared, showing significant rib rotation, some lumbar rotation, and shoulder asymmetry. And we'll just run down that. So this is the scapular and rib rotation that you're looking at, most commonly on the right, but occasionally it can be on the left. This is the shoulder height asymmetry. And you can see there the right shoulder is higher than the left. And then you can see her waist asymmetry here. So these are the key features on clinical examination that are most obvious. These were her x-rays at the time of presentation to me. She'd tried for a number of years to avoid an operation, but this was ultimately what she ended up having, a spinal fusion procedure done posteriorly from T3 to L1. So these are her pre-operative photographs, and she shared her post-operative photographs. She has about a residual curve from 99 degrees down to approximately 28 degrees. So there is still some rotation and curvature there that you can see. Obviously a significant difference between her posture now and her posture pre-surgery. One really important thing in the initial assessment of any patient with scoliosis is the red flags. And these are the patients that have scoliosis that is not idiopathic in origin. The red flags for an atypical curve are structural scoliosis in a male patient, significant pain, particularly pain at night or requiring stronger analgesics, thoracic curves that rotate out to the left-hand side, abnormal neurological signs and symptoms, and the abdominal reflex can be a particularly sensitive indicator for this. The abdominal reflex is obtained by stroking around the umbilicus in quadrants and looking for reflex contracture of the abdominal musculature. Rapidly progressive curves are also a potential red flag, and onset in early childhood, so under that age of 10 rather than adolescence. These all require referral for urgent specialist assessment where a full spine and hindbrain MRI is likely to be obtained. The clinical example on the screen is a 13-year-old boy who presented with a left-sided curve. He's been diagnosed with a Chiari malformation, which is a descent of the cerebellar tonsils through the foramen magnum that crowds the spinal cord and cerebellar tonsil region. And this was diagnosed on the MRI. And this is so severe, it's also caused a fluid collection within the cervical spinal cord that you can see there called syringomyelia. And this required neurosurgical treatment with decompression of the Chiari malformation. We subsequently treated the scoliosis with a brace in that particular case, but ultimately the young man did require surgery. What's very important with assessing scoliosis for our initial assessment, but also monitoring and prognosis, is the measurement of the Cobb angle. So on an X-ray, either AP or PA, the Cobb angle is measured by looking at the most tilted vertebra above the apex of the curve, the apex being the most displaced part, and the most tilted vertebra below the apex, and then the angle subtended by those. And most modern X-ray programs actually have the facility for measurement within the software available for online viewing. This demonstration here is of the apex of the curvature with a 55-degree curve demonstrated in the thoracic spine going to the right, and this is classic idiopathic scoliosis. The Cobb angle is important because there is correlation with risk of progression. So when we look at the age of the patient and the magnitude of the Cobb angle, this determines risk. And as you can see from this chart, young age, so 10, 11, 12, with a Cobb angle between 20 to 29 degrees, has a high chance, greater than 2/3 of progression of the curvature. As you get older, that Cobb angle being a bit on the higher side is less important in terms of progression risk. And so when you're over the age of 15, if you have a Cobb angle between 20 and 29 degrees, there's a less than 20% chance that your curve will continue to progress. Spinal growth velocity in girls is important to understand, and the typical presentation of adolescent idiopathic scoliosis is between 11 and 15 years of age when spinal growth velocity is at one of its peaks. Actually, spinal growth velocity is highest in very young children, but we don't see scoliosis very commonly in that 0 to 3 age group. We do see it more commonly in these teenage years when kids are growing very rapidly. We can also assess the amount of growing that a child is doing and left to do on what's called the Risser sign, which is looked at on an AP or PA pelvis X-ray. It's basically between 0 and 5. Grade 0 or 1 means that there is substantial growth remaining. Grade 2, 3 or 4 means only minimal growth remaining. It is judged by looking at the ossification of the iliac apophysis on top of the pelvis, and it's graded from outside to inside. So a younger patient will have no ossification, and at Risser 1, the ossification starts from the lateral aspect of the pelvis and moves towards the medial aspect. This is the historic way we've often measured potential progression and growth remaining, but it is a little inaccurate, and we've moved on in orthopaedic spinal surgical circles really to the Sanders classification or a hand X-ray, which is a bit more accurate. And one of the reasons for that is the Sanders maturity score really can go a little more into depth about how much growth is left in the Risser 0 category, which is quite a broad category in terms of growth. And you can see here the Sanders maturity scale versus the Risser sign. There is some correlation, but the Sanders maturity scale has more depth to it, and is perhaps a better marker in terms of making difficult decisions about growth remaining and likelihood of curve progression. So this is an example case. This is one of my patients who was Sanders 4 at 13 and a half years of age. She was near the end of her peak growth velocity, but at Sanders 4 there still is at least 18 months of steady growth remaining in most patients. The distal phalanx of this young lady, her growth plate there, is still open, and therefore, being Sanders 4, significant growth remaining, presenting with severe scoliosis. Now, even with the severity of this curve, at the end of growth, we know it's going to get worse, but there is a fairly high risk of ongoing rapid progression in this case if we don't act quickly, and I'll come back to that case a bit later on. So when we look at the options by the Cobb angle for our growing kids, a curve between 0 and 10 degrees is observation, reassurance, and perhaps an exercise program. Between 10 and 20 degrees, we're looking at observation and exercise. The caveat to that is in a very strong family history of scoliosis, say in a sibling or parent, at beyond 15 degrees, I would look at a brace. The classic indication for bracing is between 20 and 40 degrees with substantial growth remaining. And above 40 degrees, although bracing can be trialled, you do need to consider surgery as bracing is far less effective. This is an example patient of mine and the team at Scolicare who provide bracing. They presented aged 13 in 2017 with a 22 degree curve, and you can see the brace there corrected the curve fairly well in the brace, age 13. By age 15, the curve was down to 15 degrees and bracing was weaned. And in 2021, at age 17, you can see the final curve magnitude there was 9 degrees at skeletal maturity. This is a curve very unlikely to progress and compatible with full function, which is what this young lady had. So there's very good scientific evidence for bracing in adolescent idiopathic scoliosis. The Cobb angle, as I mentioned before, is typically between 20 to 40 degrees, and this is a randomised controlled trial published in the New England Journal of Medicine in 2013 called the BRACED trial. This trial was actually stopped early due to the success of bracing because the brace prevented progression to surgical range curves in 72% versus less than 50% of the patients managed without a brace. This is another case of mine, a 12-year-old girl with a 34 degree curve who underwent bracing. By 14 years old, the curve was 20 degrees, and 18 years old, the curve was 13 degrees. So a successful overall result with bracing instituted early. 40 to 50 degree thoracic curves do remain a grey area for either observation or brace or surgery. This is a slightly older patient, Sanders 6, which means a little bit of growing left to do, but not a lot, and Rissa 2. In 2022, we talked about the potential for surgery, but they wanted to try everything possible. They underwent brace treatment and so far have had a successful result over a 3-year period with reduction in the overall curve size and no requirement for surgery due to progression at this stage. A really common question in this space is about early detection and school screening. Many people remember being screened at school in the 80s or 90s, and this no longer goes on. Scoliosis Australia has a policy on this in that although school screening has been abandoned, we are encouraging people to look for self-detection, but also for our wonderful general practitioner colleagues to look for it at any opportunity in the age range of really between 10 and 14 years. Scoliosis is not a rare condition. Approximately 2.5% of all girls in the age range, adolescent age range, will actually have a degree of scoliosis. One of the reasons that school screening was stopped is that it was felt that excessive x-rays were being done due to potential false positives and overdiagnoses. This has changed a bit, and I'll come to that again in a few moments. Scoliosis Australia, run through the Spine Society of Australia, recommend the National Scoliosis Self-Detection Program, girls in year 5 and 7, 10 and 12 years of age, as a preventative health measure. This is endorsed by Paediatric and Child Health Division and the Royal Australasian College of Physicians. This is the Scoliosis Australia website, and there is a self-detection fact sheet available on here. A further resource is an app made by Scolicare, which involves simple home screening for scoliosis and is available via most app stores. So this is what we're trying to avoid with bracing, our more advanced treatment options for scoliosis. And this is a demonstration of surgery for a moderate thoracic curve of 48 degrees, which had failed brace management. This is a technique called anterior vertebral body tethering, which is surgery. It's a very powerful technique, but it is essentially an internal brace for the spine. And this patient's had a successful result at 3-year follow-up. These x-rays that you're seeing are what's called EOS scans. And an important point in this is that newer imaging technology reduces radiation exposure substantially. As I mentioned before, overuse of radiation has been a concern regarding screening or investigation of potentially mild scoliosis. However, most mainland capitals in Australia and even some regional areas now have EOS imaging, which is an X-ray scanner that has an 85 to 90% reduction in the radiation dose to the child or adolescent compared to traditional X-rays. There is another version of this technology called RAX imaging, which is an alternative with similar reductions. So I would encourage you, if you feel as though your patient may have scoliosis, to look at the local options for EOS or RAX imaging in your area to reduce the potential radiation exposure from X-rays. Coming back to surgery, this is a more significant curve, and this is surgery for a moderate thoracic curve of approximately 55 degrees, which patients undergone a posterior spinal instrumentation, correction and fusion for. This is modern surgery. It is a big operation, but with modern technology is very safe and can give very good results, not only in terms of the appearance, but also in terms of pain and function. And coming back to our patient with a more significant severe curve of 90 degrees in the thoracic region and 86 degrees in the lumbar spine, this patient underwent combined posterior and anterior fusion to get maximal curve correction. This was surgery for a severe curve greater than 60 degrees. So, although I've gone through a little bit about surgery there, to me the best operation remains the one avoided, and we have no doubt that early detection and appropriate brace treatment can avoid surgery in many cases. Scoliosis is common and is commonly not particularly painful in children. So kids can have a really severe curve and actually have no pain. There is, of course, patients that will have pain and discomfort. Severe pain is a red flag and requires urgent specialist referral and a likely full spine and hindbrain MRI. I believe it is certainly worth checking for scoliosis in well children, particularly girls aged 10 to 14 and boys aged 12 to 16. And there are a number of resources I've listed there that can help you. I think also many of us that deal with this are always incredibly happy to have a call, text message or online contact if you're concerned at all about any patient and need advice. I'd like to thank the Health Ed team again for having me along, and I'm always happy to answer any questions.